Welcome to Health Law Talk, presented by Shahardi Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
And good morning, good afternoon, what time it is that you're listening to this podcast. Welcome to another edition of Health Law Talks with Shahardi Sherman Williams. And in the studio today, we have the three originators, I guess, George Mueller, Rory Bellina, Conrad Meyer behind the mics. And sort of wrapping out 2023, we decided we would like to come do an episode on private equity in healthcare and what that means, what does that look like, and some of the issues that, I guess, when you bring in private equity into healthcare, whether it's buying out a group practice, whether it's buying a private hospital, what does that look like? What are some of the issues that you face as a provider dealing with private equity, and what does that usually mean, could mean for the public, good, bad, or not? And so it was a good topic, especially timely because of some of the things that are going on in the news, some of the things that are happening in politics, especially on DC. And so we thought it was a great idea to bring it up. So I'm going to defer right now. Rory, George, what do you guys think? Private equity healthcare 2023 getting bigger, smaller? What's on your radar when you think of private equity?
I definitely wouldn't say that it's getting smaller. I would say that it's continuing to grow, and that you see these private equity companies are targeting slowly but surely different sectors, different practice types. There was a trend for a while to do dermatology, and now we see that shifting to more of like the surgery center spaces because they see that the revenue comes in from so many different sources of providers. But I would not say that it's slowing down. If anything, I think they're just looking at new areas to expand to or maneuver over to.
I would echo Rory's sentiment and then say that I think that there are certain groups, groups of money people who want to roll up and acquire certain specialties and subspecialties. And so as kind of acquisition penetration occurs regionally and throughout the country in certain subspecialties, you'll find ebbs and flow of which specialties are getting bought up and at what rate and what size and what region. So I think within specialties, there are different kind of speeds and I guess ages insofar as who's buying what and where.
So when you say the ebb and flow, and I understand where both of y'all are coming from, what's been on your radar this year in terms of the specialties and of the spread of private equity acquisition? We've gone from dermatology, like you said, Rory. What have both of you seen the expansion? Where is it going now?
I think we've seen certainly in imaging, that there's a lot of radiology roll-ups going on. Seen dermatology is another area where I think in some surgery practices, of course, we've seen that as well. In different areas, we do have sort of a different, like in internal medicine, to some degree, you have insurers who are sort of sponsoring clinics or opening clinics and then trying to staff those with internists and then using practice extenders to be able to leverage down and try to penetrate the internal medicine, primary care, family care market in certain particular populations. But I think if we go back to the first two examples, radiology and surgery, I think and derm may be perceived to be some areas where private equity, through how they structure and manage, can frankly make some money and do well, efficiencies, so to speak. I think a lot of owners turn into employees, which compensation is a little different. Also, I think from a macro perspective, you have to realize that the population of physicians and their age relative to where they are in terms of
seniority.
Well, where they are in terms of their horizon, their personal horizon.
Right.
They may be at 60, 65, and you really start to contemplate within that 5 to 10 year period, how much longer do I want to do this? Mm-hmm. How much longer can I do this, depending on how physically demanding your specialty is? And I think derm versus orthopedic surgery, arguably.
Because when you say surgery, you mean ortho, cardio, neuro? Is that what you think?
I was thinking
the
primarily
top three?
ortho. I think I'm not. Now we have had some right in Louisiana. We had
the cardio, and we've had some neuro.
Cardiology Institute of the South was recently acquired.
That's right.
So I think those specialties, and there are probably a bunch of others if we were to do the research and kind of line it up to the extent those deals are reported. But I think you see basically as the provider, as the physician owner population ages out, you will see that more people starting to come into that, and then the structure and the availability of money has been, plentiful. So if you add all that up, you're going to get some consolidation, right? You're going to get some roll-ups. And so, but the younger physicians really aren't in a spot to sell out yet, right?
Right.
And they maybe don't want to. They like owning their own practice. They like kind of making their hay, so to speak. But I think when you get to a point where you're 65, 68, 72, maybe you start thinking about it. And then so you're more likely to be someone who's going to sell your controlling interest and bring along your partners, structure your retirement in a way where you're going to work 3 to 5 more years, maybe get the air quotes rollover equity, and then hopefully you get their second bite at the apple 3 to 5 to 7 years after that.
When we talk about a private equity deal, Rory, what does that look like? I heard George touch on it a little bit. What does it look like from a practice standpoint when you've got private equity contacting a group practice and saying, okay, we want to come in? What's been your experience when dealing with a deal? How's it structured? What do you see?
I mean, it could be as fast or as slow as the acquiring company wants to go. A lot of times before they do anything, they'll get the confidentiality agreements in place, and they're going to want to look at the financials to see, is this even worth, the go or no go analysis? Is this even worth proceeding with? And that seems to take a huge chunk of time. Once you get past that, then they'll start asking more, and that's when you start to see like the data rooms open and start to look at, okay, well, let's look at who are your vendors, who your provider contract with. We need to see your billing, which is a whole other separate issue. To start to look and see, the next step of this, do we again want to proceed? And then a lot of times it like George mentioned, is what is the demographics of the practice? Is it a practice where you've got a lot of older providers on top who own the majority of, let's say, the stock in the company, and they're going to use this as their way to cash out, and they'll be employees for a couple more years and go? Or do you have, and you could have a split where you have that group, but then you also have a lot of young employed physicians who they're straight out of residency that have been in this practice that's now going to get purchased by private equity, and they're going to become an employee, and that this is not what they thought that they signed up for. Maybe they thought that they were going to slowly buy into this practice and become an owner. And so you have to juggle that, because the purchaser wants, most of the time they want to keep all the providers in, because that keeps the cash flow going. And so you don't want all the young physicians to quit. You definitely don't want the older ones to leave, because they have the established patient base. So that becomes a delicate balance, as well as trying to keep everyone happy. And how do you keep, the older physicians that own the stock in the company, they're going to be happy because they're going to get paid out the most. The younger ones that really have nothing, figuring out how do you keep them in and keep them happy to be the workhorses when really they're just going to be earning a salary and they have no shot at getting ownership. I think that becomes a delicate talking point. I know, George, we've gone through that with some different clients. That's always a juggle to deal with, the breakdown of the older tenured physicians.
Yeah, their investment expectations, I think their professional horizons and what they want to do for the next 10 to 20 years are two dramatically different groups of people.
Right.
And both are pretty critical to the continued cash flow based on the model, based on the enterprise value, based on the spreadsheet. That's the decisional framework for private equity coming in and buying, right? When they set all that, they've got to presume all the information about current revenue levels, future patient retention, and then case money, collections, et cetera. All that has to be considered when they put a price on it, right? And so they've got to be able to retain those people. Obviously, employment agreements and retention of a certain amount of people are kind of key, because all those revenue assumptions are based on that. So they've got to keep those in there.
And we talk about revenue assumptions and how they value, meaning private equity values a practice. And I know the three of us have mentioned this before when looking at a deal, but are we seeing the similar trend across the board with private equity coming in and dangling the carrot in front of these doctors, knowing the demographic makeup of the practice, where they say, we're going to give you a 10x multiple or even higher, and then during the whole modeling show, the whole beauty pageant. And then suddenly, as we start getting into the LOI and getting into the definitive agreements, and reviewing, like Rory, like you said, the data room of the actual vendors and the payer mix and so forth, that multiple seems to decrease a lot.
Right. Yeah.
And then you have the holdover, and so now when you really get down to the actual closing of the deal, it's not as sweet as it started.
But you're so exhausted from negotiating it,
right,
and spent so much in time and attorney's fees that you just want to close.
How often does that happen? Is that a strategery thing from private equity?
Every time, and you call in you call in the most complicated attorneys at the end to muddy up something, to have more money put in escrow, or to lower that projection a little bit. And we see that every time, and kind of expect it. That kind of like with buying a house, your first offer is your best offer. Same thing with this. The first number that they're going to give to you is as good as it's going to get, and it's only going to go down from there. So, but it's hard to, we've had stories.
Sure.
About that.
So when, depending on how much information particular pursuer has on a given target, they may have the indication of interest is usually, hey, this is what we've liked, and we kind of get, as Rory was saying earlier, confidentiality. Generally speaking, if they're working with a broker, then the broker will usually have some sort of a deal book available that has some sanitized but fairly specific parameter information as to revenue level, number of physicians, all the key drivers that any particular buyer would want to see to arouse an indication of interest.
Right.
And then from there, they may develop some expectations and then look at what their enterprise value is and kind of set up. So you have these couple of working pieces. You have the enterprise value, which is that total of EBITDA times a given multiple, right? Like the big shiny object at the top, right?
That's the carrot.
Star on the tree. Boom.
That's right. That's right.
And then, because we're seasonally appropriate here.
Star, I like that.
And then but then you've got to look at, A, are they going to keep the multiple there, right? And B, that enterprise value, that EBITDA. So what normalizations, air quotes for those of you listening, are going to impact that number once they get into the data room and look at it and start to beat up the quality of earnings.
Well, we usually have it on the group side. So, I mean, that number, that multiple that all of us are talking about right here, the star on the tree, right? That is, it's so hard to manage client expectations, because when they hear that number, it's usually before we even get to them. Right.
It's usually at a steak dinner.
It's usually at a steak dinner or some
office.
kind of right. And so by the time we get it, suddenly we have to manage clients' expectations and saying, well, they said 13x or 12x or 15x.
So to put it into numbers, it's the letter says, we believe this thing's worth $150 million. And then the ling, 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 the little dollar signs are going off, and it's hearts and flowers and everything.
Start to mentally spend.
There's a lot of hearts and flowers, right?
Mental millions are spent instantly on second homes, third boats, and fourth whatevers. I mean, just everything.
Sure.
Right?
Sure.
So
that's hard, though. It's hard to manage that.
It's human nature, and believe me that these things are played upon because of that. So then what happens is that number will begin to erode, right? And it typically erodes for valid reasons. I mean, they're going to come and say, well, hey, look, this physician's not going to be here that long.
Right.
Or, hey, we're expecting some headwinds on this cost. Or, your reimbursement on this is probably going to go down because there's going to be some downward pressure because the charge master is going to go down, or because whatever derivative, Medicare schedule we're using is, they're going to squeeze that more, blah. Then all the parade of horror suddenly comes out. It goes from hearts and flowers, 150 million, to erode. Look at all these things. Look at this. It's terrible. It's like you've hired ex-brothers inspectors to go into your house and shoot holes in the thing.
And while it's eroding, and the erosion is being put in little buckets that you can only touch at certain points in time. So that 150 million, for your example, might now be down to 130.
Right.
But $30 million of that is going to be put in escrow, and $20 million is
For
going to
2
be
years.
held
For 2 or 3 years.
Some of this is rollover, so it's not
Right.
We haven't
dollars.
gotten to that rollover yet because that's a separate big deal because the enterprise value is the whole pie.
Yes.
But they're not going to buy the whole pie.
Right.
They're going to buy a piece of the pie.
Okay, so let's talk about that.
But they're
'cause
going to have 100% control. And so the idea, and look, if you have, let's say you have a pot of money. It's
Right.
like $2.3 billion at Crud Rock Inc. or whatever, right? And so you got a bunch of guys in the Patagonia vests, and they're all doing their thing. They have a spreadsheet, slick fast, got to use a major firm, blah, blah, blah. So if those guys, they have a limited amount of money. So they've got to shoot the biggest elephants using the fewest bullets as possible. And so
Right.
that's what we see. You value 100%, but they're maybe going to acquire 65%, right? And you're going to get 35% of rollover equity to all of those key partners and the other people. But you can have 100% control, and that 35% is locked up. Like it's hard to get a put on it without giving them a call, right? And then there's no guarantee. You can't just go and say, hey, in 5 years you need to buy me out of my
cash
same
out.
multiple because I really
Right.
want to be out, right? I'll take the ride. I want my second bite at the apple because you said it's going to be at a 13x, not at a 9x that you're buying. It's at, wow, that's 4x more. And it's tax efficient. So everyone has a script that they follow. First thing they say is, well, you're going to get way more on it. You're not going to pay tax on it, so it's very tax efficient. You don't have to pay that tax. And you don't want to have to redeploy it in another investment. They say all the things you don't want to do with your own money in your pocket, right? Besides, say, spend it, give it to your kids, or reinvest it in something that has nothing to do with what you've been doing for the last
Right.
30 years. All those things really play into what happens. And it's some people like it because if they're young enough and they're going to be involved enough, then, yeah, they'll take the ride on it because they believe in the company they built. They're going to sell it. They think it's only going to get better.
They drank the Kool-Aid.
And it may well though. I mean, to be fair, some of these things do work out favorably.
Yeah, sure.
I think this particular discussion point really emphasizes the importance of trying to get a put right or an exit right for your seller who has that carryover equity in terms that, if nothing else, if they really want to get out, and
Right.
it kind of depends on their age and their investment horizon, but if you can get them a guaranteed out at no less a price than what they sold the day you did it, then that might give the buyer, private equity co, an opportunity to buy them at the 9x when it's worth 13. They're going to sell it. But if you want out now, you may like that, right? You may not want to wait, or you may be ill.
Well, you
A
might
lot of
want to
things
do it
happen,
now
right?
because you're not going to have control. Once the deal closes, you're done. And so if you don't exercise it before, you're going to lose
Right.
it.
And so with that kind of, just generally speaking, rollover equity, they like it to be as close to 30, 40% as possible. I think sellers, depending on their tax scenario, if it's been around 20, 30 years, maybe some anti-churning things, some rare tax stuff that happens with corporations, then you may not want to go above 20%, right? And you want to get as much. Problem is they've got to use more cash or more debt financing on a company you're going to buy. So it's either way, whether they're putting their own cash up from that big pile of money we talked about a few minutes ago, or they're going to go borrow. The company will borrow debt and pay you with it. But the borrowed debt directly devalues. It's on the balance sheet of the rollover equity you have, right? So one way or another,
You're going to earn it back over the years.
one way or another, it's out of your pocket, right, as a seller. And so that's a critical kind of economic distinction to make when you're doing that.
And see, let me just
But
say
in any event,
this.
you get no control. I mean, they're going to run it. They're going to have the back
Right.
office, as we're going through a list of kind of talking points that y'all can't see on the in your earbuds. They're going to really kind of, the idea is private equity is supposed to pull out the money by managing it, by providing financing, by doing all the payroll. It's going to be a management services agreement. They're going to streamline, by the way, you're an employee now. So even if you work in a magical RVU thing, you're probably still making less and you're not going to get those same equity distributions.
That's
So
right.
it's a little less money. So all in all, it's a good economic prospect, but it is a liquidity solution for someone who wants to get out. And
All
so
right.
that's not all bad.
Very complicated concepts you just said, and I know, Rory, you've dealt with that too, but let me ask you this, guys. How hard is what you just digested in a very, very good summary in in a few minutes, how hard is that to relay to providers when doing a deal after they've been told at the steak dinner it's going to be a 13x multiple? Because now you're walking it back because they have
I
they
think
have,
it varies. Honestly, it's humans, and so I know we all have different clients with different aptitudes and different attitudes, and
Right.
different. And so some may be absolutely just focus on that, and they're going to go, and they've kind of persuaded by
like a ready,
the big
fire,
notion.
aim.
But I think to their credit, a lot of our physician clients are very shrewd, and they're not just fabulous practitioners, right? They're not just really good at what they do with their subspecialty. They read a lot. They're polymaths. They're bright. They're good business people. Not all of them, but some of them are. And I find the ones that have a tendency to be good business people immediately understand the economic alternatives and pivot points of, control versus liquidity versus price versus the normalizations versus, as Rory was talking about, even, the last second healthcare. Healthcare compliance and regulatory issues never come up in the first 30 days of a deal. They always come up in the last 10 to 20 days.
Right.
And it's always someone who's in a corner in a little fax office somewhere. They don't have particularly good social skills. They have a tendency to be very verbose. You almost like you can, when you're on the phone with them, they're avoiding eye contact with you on the phone. That's how awkward it is. And it's just basically their regulatory wonks. And they're like engineers, they're like light switches. God bless, we love our engineer clients, but it's all or nothing. Everything's immediate report, full blah, blah, blah. Everything is like to the max or you're going to die, right? I mean, it's literally an on-off switch, which is interesting because a lot of these things really do have a subjective factor to them. Some of them are objective, but I think they're intentionally brought up at the end and say, oh, look what we got to do. And all of a sudden more money goes in. And it doesn't hurt, the buyer doesn't care. They're just going to take the money they would pay you and report it to buy, quote unquote, regulatory peace and quiet.
Right.
And where there's a lot of practical issues is about how efficacious those claims would be. And of course, we don't advise people to not comply with all federal laws and regulations, but it's just at some point in time it becomes kind of, for lack of a better term, what's the word you would use? Where something is just absolutely, maybe technically there's a concern, but from a practical standpoint, anecdotally, it's a total nothing burger. And so, I mean, that's...
I don't know if there's a term for it, but I agree with that.
Right.
You have those situations where it's, like you said, it could be very subjective, and that regulatory attorney wants to do a self-report, and it's going to go to Washington and sit on someone's desk for a year, and they'll gladly take your money, and that's it. And there may not have been there, but like you said, I think what brought us to this conversation was, issues going on nationwide about kind of there was a large private equity company who purchased up a system and purchased up a hospital, and there were some issues with staffing there, and that got Congress involved. And the larger question has been presented: is private equity good for healthcare or not? And I think that, yes, it's good, but I think that in some spots, maybe it's not good. So I'd love to hear both of your opinion when we got about 10 more minutes left in this. Overall, good or bad, and how it's helpful, but also not.
So it's always, we've seen it happen in the insurance sector, and I think we're seeing it happen in the hospital sector. And then I don't think physicians there's a limitation on physician-owned hospitals now from the Affordable Care Act.
That's right.
And so overall, if we view this more than just, through a keyhole or a telescope and see the broader issue, things seem to continue to be moving towards consolidation, right? And so you have consolidation of common ownership and control over various practice sectors, right, that are either because financially or just situationally they're more ripe for acquisition, right? And so because funds will naturally see, if we have this money, we're going to buy groups. Who are we going to roll up? Where can we make the most money? Because that's their role. And then what are most susceptible to roll up for those various drivers? I think when that happens, invariably you get larger groups. Larger groups typically means more bargaining power, right? Because they have greater percentages of market share in any particular geography. And contracts are kind of state by state with respect to various insurers. So all that in your larger cities where a lot of these roll-ups focus because of patient population, right? I think you just see continued consolidation. Now, if you're of the big theory that government kind of wants to consolidate everything because someday we've got to go to single payer, right? Because that's what everyone else in the world does. But everyone else in the world comes here for healthcare. It's just Like there may be a correlation, maybe it's just coincidence. I don't know. I want to get political here, but I think the point is that the government doesn't seem to want to allow, like if Humana wants to merge with someone that were trying to merge earlier, that got blown up. I think Elevance and someone else maybe were trying to merge. They had to go back and change their terms. It's strange because while antitrust and FTC issues certainly abound with respect to consolidation and whether or not you need a Hart-Scott-Rodino issue, but I would think they would want consolidation because eventually, if they have all the tuna in one bucket, how easy then is it at some point in time to just take the one bucket and let them all swim into the bucket freely? Because I think that's what I see happening. Now, that said, it gets interesting for patients, it gets interesting for payers because you lose the ability to have multiple choices to go to if everyone's kind of getting bought up in or consolidated, right? Industry by industry.
Yeah, I echo that, and I'm thinking more operationally from a private equity standpoint when you take over a group practice, a surgery center, even still a private hospital, because they can still take over private hospitals. They can even buy hospitals now because they're not providers, so there's no prohibition on that. So they can go out and buy a system like what happened here. My question is what happens when you get private equity administrators who are really focused on profitability, and we all talk about, well, they could debt service, they could upgrade whatever, but really what they're going to be trying to do is, because the continued fee schedules are being scrutinized every year at CMS, which all private payers, not private pay, but commercial payers then follow the suit, right, from CMS. Then if I'm private equity, I'm going to be trying to decrease my expenses any way I can and maximize reimbursement any way I can.
Well,
so how do I do that?
Patient care isn't compromised. I mean, we still have really good physicians.
It's easy to say to anybody, though, George. I mean, everybody can get on a podium and say, we're going to give you high-quality, low-cost health care. And how many times have we heard that? But when you get down on the front lines, it becomes a different story. Like, for the example we were talking about before the show, the issue of telemetry monitoring, the remote monitoring. So, I mean, I've watched over the years the remote monitoring go from, one monitor to 10, 20 patients to now I'm seeing 40, 50 patients. Okay.
Is there a standard of care for
we've
even
talked
with
about
all
that.
The tech and
interestingly, I know that I saw the other night where where HCA was saying that they have like a 40-to-1 ratio or something like that. It was on the news, and they allegedly abide by the guidelines that the American Heart Association says, which is 40-to-1. 40 patients to one monitor. And then I saw the AHA says, well, we never said that. So I don't know if there's a regulatory baseline on the monitoring, but my point is take that aside, that they're private equity, when you have an administrator from private equity come in for a group, an ASC, or even a system, you got people who've never had any healthcare experience come in, and their sole focus is to cut the fat, get rid of expenses, and how can we do that? Like, I'll give you an example for a for-profit hospital situation, and I'm not going to say who it is, but I witnessed this. I watched this happen. Med-surg floors used to be, med-surg floors would have 20, 30, sometimes 40 patients on a med-surg floor, and you would have at least on a 4-to-1 ratio coverage, maybe 6-to-1 ratio, where you had an RN covering that kind of patient base, and it was all RNs. And so I know for-profit companies come in and say, oh, we don't need 4 RNs on a med-surg floor. We need 3 LPNs and 1 RN to monitor all the LPNs. So is that patient care? Is that quality? Do we go from monitoring a 20-to-1 telemetry to a 60-to-1? Is that quality? Do we go from having 10 sets of hardware at a hospital because each surgeon likes to have, their Medtronic, their Stryker, whatever hardware they like to do their cases, to where we're going to have 1 set? Kind of like going to a tool like an automotive mechanic. Some might want Cobalt, some might want whatever. Snap-on, right? But yet Matco, and so then you say we're only going to have 1 set. So I mean, there's ways to streamline it, but what I see operationally is I don't see the good outcomes from that. I see examples of the bad outcomes. Now, I guess I'm wearing tinted glasses. I like to see the good outcomes, but I don't know how you can look at someone and say putting a 40 to 50 to 1 on a telemetry monitoring is good for healthcare. I don't know how you could say for RNs now we're going to take away those people and give LPNs. I don't think you can do that.
As a split of industry
I'm using it as an
issue,
example.
Yeah, do you think that because of the nature of the services, do you think that maybe that private equity consolidation has more of a potential negative effect on quality of care for, say, facilities versus practices?
I think that yes and no. Yes, I would say for facilities, yes. Practices, what you're going to have is
because the physicians are still providing the care.
Right?
That's
right. They're going to cut the fat out of those practices. So if you've got a low performing doc,
right,
like that person is going to be gone, right? And then how many mid-levels how many APPs do you really need to cover for a given practice? Because, a lot of docs want their APPs to do their closing, their opening, and so forth.
They have an optimization calculation.
I'm sure they do.
And which is pretty lean and probably has a little ouch factor with it. And they strive to push it towards that ouch factor without causing a revolt.
And let me just say this, and I'm going to say this to both of you.
That's where most of the pressure points in those sort of operational quantities.
I'm going to say this lastly because I do think there's a good point on private equity acquisition of facilities, and I'll tell you the good point. I have watched over the years, because I've been in healthcare for almost 30 years, even from an administrative side, okay? How many administrators do we need to run a hospital? How many? Because every time I look, and I bet you, if you ask the providers this question, they would shake their head. I agree with you. How many VPs of X do we need to run the facility? And if you look at an org chart, it looks like a freaking spider web. Because you're looking at it like, oh my gosh, we have a VP of what? We have a VP of this?
Yeah, so there, I think.
Sorry.
No. What I was going to say is.
Do y'all agree, disagree?
Well, I will say this. Certainly in the air quotes spreadsheet that they use to look to analyze earnings and come up with enterprise value based on operational management and budget assumptions, I think they certainly achieve some efficiencies by having some more remote or regional back office crammed into the quote-unquote MSA that typically gets signed. And I think it's the same probably with hospitals to some degree. Obviously there's going to be some, the Bobs will come and ask you what you do, right? And say, so what exactly do you do here?
Great movie.
And so, metaphor, and that happens in all industries, not just healthcare.
No, but look at
everywhere.
I would ask both of you to look at the ratio of administrators to providers in a facility, and then look at the ratio of administrators to providers in the system.
Now, there's a lot of paperwork. There's a lot of paperwork and a lot of nonsense involved in the provision of health care.
Well, you have your back office for that.
Effectively that's what they are.
No, I'm talking about administrators. I'm not talking about your back office staff for claims, and I get that. I do get that.
Right.
I'm talking about your VP of admin over business development, for example, or marketing, or whatever feel good you want to title someone as a VP of something. Look at your administrator to provider ratio.
Yeah, I think what happens is with size of organizations, those have a tendency to grow because people who would be responsible for multiple parts of those just don't want it, and they appear that there's maybe room in the budget. And I think again, it can grow like government, right? And nothing grows except for maybe kudzu. In Mississippi, nothing grows like government, right? Because once it goes, it doesn't stop. You can't retard it. You can't eat it.
Love your
analogy.
You
can do with it. And so,
most people who are not from Mississippi or don't even know what kudzu is. It's like a weed, and it starts and it just grows at an exponential rate.
Doesn't stop.
Does not stop. It's a vine. Anyway, that's what I thought, Rory. Sorry for the long-winded answer.
No, it presents, and for law firms, it presents great opportunities.
It does.
To advise your clients through a critical kind of one-time sort of practice exit. For us, it's advising them on the culmination of valuing a big component of their life's work, and then making sure they maximize value for that, and then they have an appreciation of what those exit points and what those value parameters are going to be, when the deal's done.
Well, good.
All right.
Well, gentlemen, I think I know Rory had to roll out, so we're going to end this a little early. I will tell you this.
I think we scratched the surface. There's a lot
going
we could
below
probably
here.
hit this topic with a lot of depth on either how the deals are structured and kind of a narrative
Right.
of what goes on at various stages, to say, as you say, to kind of have a particular client digest that, and then maybe go into a little bit of some of the regulatory issues that we've been seeing with respect to how
Sure.
Congress views it, what their attitude towards it is, which I think is kind of duplicitous. I think in one way they want consolidation. If they want single payer, then you've got to have consolidation to get all the tuna in a bucket. At the same time, they don't want consolidation in a way that, upsets the air quotes balance of power with things.
But let me just say this. And we'll get to that. I think let's ask the listeners here. So, if you are interested, anyone listening to the podcast that wanted to do some additional, like maybe a multi-part series on an in-depth private equity transaction and the issues that we face, give us an email. Send us an email. Let us know what you think, and we'll be happy to look at this and maybe add some more, I guess, colorful commentation and discussion and future series. So, gentlemen, thank you very much for this. Rory, Belina, George Mueller, Conrad Meyer here. We really appreciate everybody. And look, it's getting close. I think we're doing this week. We're close to Christmas, right? Yes, we are.
I'm wearing my plaid, which is red and green and everything else. Ho, 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 Merry Christmas.
Yes. So for those of you who are listening to this around Christmas time, Merry Christmas to you and your families. I'll enjoy. And until next time, we'll see you soon. Take care.
Thanks for listening to this episode of Health Law Talk, presented by Shahardi Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardi Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardi Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.